Good morning, everybody in your time. I'm going to talk to you about the imaging for the renal failure today. This might be the last my talk in this semester. As you know, kidneys are in the retroperitoneal organ. Kidneys are in retroperitoneal space, as you see on this slide. And the kidneys are roughly 11 by 6 centimeter if we see on coronary images. And so that the right kidney is a little bit smaller than left kidney, and they're about 150 gram. That's about, so this width is about 3 to 5 centimeter, and also depth is also 3 to 5 centimeter. But the elongated length is about 11 centimeter, and the left side is a little bit bigger. As you see here, we have a pancreas, aorta, superior mesenteric artery, and the adrenal glands in front of and superior to the kidneys. And so this space is called peri-renal space, peri-renal space. If you have a certain disease with peritoneal seeding, you will see nodula, all this around the liver and around this kind of, this is called lesser sac, and this is called subhepatic space, and this is perisplenic space. Another, okay, this is peri-renal space, and the outside called para. Para means a side, para-renal space. So Gerota's fascia, the fascia is dividing those things. So you always look at on CT, this fascia. So if there's something inside, that's called something in the peri-renal, a little bit outside around, that's a para-renal space. That's terminology we have to use. As you see here, like every other organ system, with aging, the parenchymal tissue of the kidneys become shrunk, less cortical volume, cortical, and some cortical medullary sort of a ratio become also decreased. So just like a brain, there's some roughness on the surface, and we see quite a cystic things in the kidneys with aging systems. It's just like any other organ system. So that's degenerative processes. More detail inside, as you know, and the cortex, medulla, and the glomerular is here, and this arcuate artery here, that's a sort of a arterial branch, and then we call this this pyramid, and here is a papilla, and then you have a calyxial system, and this is draining side, this is pelvis drain, renal artery branch, and arcuate, the branch here, and the renal vein comes here. And so in this diagram, you can see glomerulus efferent arteriole, and the efferent comes in and go out, efferent arterial comes in. So in the, for example, rejection by immunological phenomena, the outflow efferent arterial become shrunken, and so the flow to the kidney become disturbed. That's usually vascular phenomena in rejection. On the other hand, this hernia of loop, proximal and distal, and for the tubular secretory or reabsorption function here. And it's a structure here connected to the draining collecting system. So this, if something comes here 100% in glomerulus, filtered in 80% in most DTPA, other chelation agent, but 20% goes out into the tubule for tubular secretion and the some reabsorbed. Okay, and so in the kidney, tubular secretory function is the main function. Glomerular filtration is a passive function, the second most important. And then tubular reabsorption is also a passive function, third function. Those are three major functions. So why we need this function? Because we want to get rid of all waste material from the body system. And from particularly muscle metabolic process generates a lot of waste molecules that go through the kidneys by filtration, by active secretion from the tubule. And so, and the creatinine is from the muscle transported to the kidneys and going out. But you can imagine any toxic drug like a chemotherapy agent, particularly platinum-based chemotherapy, is going through the kidney so that kidney tubular cells can be damaged by such a toxic drug. So in such a cancer patient, we encourage them to drink lots and lots of water to wash out those toxic drugs. But any bacteria, virus, all kind of things go through kidneys and makes kidney diseases. And also this function is all sort of related to vascular system. So if there's a certain hypoxia, particularly heart disease or some of the brain disease, it affects renal function. So that's why brain, heart, kidneys are all working together by the one axis. So clinically, we measured BUN and creatinine, serum creatinine. Serum creatinine is a little more accurate than BUN for estimation of renal disease. So serum creatinine here, and in the clearance about here, this are normal data. But because of certain less sensitivity, also we clinically measure the BUN to creatinine ratio. Usually normally 12 to 20, so around 15 plus minus, that's the usual. So if this ratio is low, we have to think about acute tubular necrosis. Although some other liver disease, you have to rule out low protein intake, etc. If this ratio is high, the pre-renal disease, some vascular renal arterial stenosis, etc., and or high intake of protein. And if the ratio is high with the particularly increased creatinine, that's obstruction, renal obstruction things, or uremia advancing. So again, kidneys remove certainly certain waste product and also clean the blood. So it's like a dialysis function. And to control red cell and also blood pressure. And also many certain chemical compositions should be in balance. So kidneys are trying to control that thing. So kidneys are so important in maintaining our body function. Anatomical evaluation can be easily evaluated by intravenous urogram or retrograde pyrogram. Retrograde pyrogram, you can see collecting system, papilla here, and so but the intravenous can show better with ectasia, tubular ectasia here, you can see. So sometimes if there's some kind of urologist, usually put the contrast through the urethra and then demonstrate any stone, any obstruction, etc. But if there's a kidney, certain parenchymal disease, intravenous urogram is usually obtained. And obviously ultrasound showed anatomical abnormality very easily. So if there's any renal disease suspected, the clinician usually starts with the renal ultrasound. And certainly you can see cortical thickness, and certainly using Doppler flow phenomena, and then resistance. Using Doppler, they can measure resistance from the some vascular systems. And then now a bubble sort of a contrast can also evaluate any vascular disease and also some enhancement of certain mass lesion. So in details, you can see very good outline of kidneys. You can measure the whole length, width, depth, and some collecting systems and cortical thickness. And the CT without contrast, it's not easy to see the cortical medullary junction or things. So, but in suspected stones, things, non-contrast study should be obtained. And this ultrasound Doppler study, vascular structure, and they measured the resistance of the certain arcuate, some renal arterial branch. And so by using a certain contrast agent, just like a nuclear medicine study, they can make a time activity curve, not activity time, sort of a signal ultrasound echogenicity curve, and make this kind of renogram type curve. And also recently ultrasound elastography, like hepatic elastography, it shows elasticity. If the renal fibrosis, certain rigid conditions occur, this will show them, but it's still in research rather than practical. And in CT, using serial sort of dynamic images, we can demonstrate nephrographic phase, excretory phase. And you can cortical medullary junction, and you can evaluate all anatomy very in details, and also excretory function things. So just like a nuclear medicine, nuclear renogram study, they can also generate the same information. And so this one, certain right side, it has some cystic, very well-defined certain lesion, but here surrounding some ill-defined, some low density and some kind of, and you don't see some this kind of similar this nephrogenic phase. You don't see it. This case is actually crossed, fused ectopic. Some congenital anomaly show this kind of ectopic or fused together in one place. And the hypoplastic kidney. So this is a small sort of a soft tissue, but looks like a renal configuration, small. So that's a hypoplastic congenital. And this, oh my gosh. You can show nuclear medicine study. Right in small, it's right here on posterior, this is the liver, but the ectopic left kidney is down in the lower abdomen in the midline here. So sometimes we see this kind of anomalous kidneys. And the MRI, without contrast, you can also demonstrate so cortical medullary junction or the collecting systems easily. So you can see a connection here very well on T1, sort of a post-contrast gadolinium study, delineate cortex and some medulla connected. This horseshoe kidneys, another congenital anomaly. And then the MR also can generate split renal function, outlining very precisely the cortex, the medulla. You can generate a sort of a time and signal intensity curve, just like a renogram curve. And also you can demonstrate all the major renal artery and maybe some blockage or narrowing, you can see. So MR, you know, has multiple sort of pulse sequences to make diffusion imaging, certainly ADC map imaging, and certain tractography, just like a brain. So evaluating some kind of connectivity or a molecular sort of water movement. So a lot of pathologies may be shown on this kind of things, but this is still under sort of investigation or clinical. It's not routinely done. For nuclear medicine renal scan, we have glomerular agent and tubular agent. In tubular agent, we have tubular secretory agent or tubular fixation agent. It's sort of nothing goes through 100% through the glomerulus. Inulin is about 99% filtered by glomerulus, but still 1% is tubular active secretion. And so inulin is the gold standard for glomerular filtration. Now, as I mentioned earlier, this kind of chelation agent, technetium or chromium, iodothalamate, is technetium DTP, for example, is 95% filtered by glomerulus, but 5% is active secretion. Now, Hyponatremia, labeled with iodine 123, or iodine 131, is actively secreted from tubules, proximal tubules,
but that's about 80%, 20% is filtered by glomerulus. Now, mercaptoacetyl glycyl, 3 glycyl amino acid together. These behave very similar to heparin. So it's about 80% is actively secreted by tubules. So that's why using technetium 99M, we can inject a very high dose, like a 10 millicurie or 20 millicurie. This iodine 123 is cyclotron produced. Iodine 131 has a very high energy and also get beta ray. So we cannot inject more than 1 millicurie, so that we cannot generate dynamic sequential images. But technetium omega-3, we can generate a dynamic. So we can have a dynamic flow study and also perfusion images. So at this time in the United States, we are using primarily technetium 99 and MEG3 for evaluating blood flow phenomena as well as tubular functional information. Now, technetium dimercaptosuccinic acid or glucoheptonate. Glucoheptonate is no longer available commercially, but DMSA, we still use DMSA for more like a pediatric renal study, because this is also glomerular agent is filtered by glomerulus about 85 to 90%, in contrast to 95% by DTP. So there will be more tubular active secretion, like 10, 15%. And also this tubular active secretory function is relatively slow. Glomerular filtration is relatively fast, it's dumping. So it stays in the tubules longer than DTPA. Therefore, it outlines the kidneys much better than DTPA. So this agent has been used to evaluate cortical abnormality, cortical thickness, cortical irregularity. So in patients with pyelonephritis, glomerulonephritis, there's some sort of a scarring in the cortex, scarring. So on CT, MR, ultrasound, sometimes the scarring raises a question about small peripheral certain special companion lesion. In that, we can use this agent to delineate the functional anatomy, Okay, so you have to understand the different functions of this 3 common agents we are using in nuclear medicine. So this is cortex medulla. Okay, so when we say obstruction, urinary tract obstruction is right here, this draining obstruction, blockage, or intrinsic or extrinsic. But when we say tubular obstruction, is right higher here, hernia of loop. So in acute tubular necrosis, for example, tubules, the material cannot either secreted by tubules or reabsorbed. Only technetium 99M pertechnetate, filtered by glomerulus in almost 95%, but almost all reabsorbed from the tubule. That's a technetium 99M sodium pertechnetate. Therefore, we don't use it for renal scan because it's circulating continuous, filter and reabsorb continuous. So it's a glomerular filtration agent, but it only shows flow phenomena. You cannot talk about tubular function at all. So for example, here, okay, this is a serial every 4 seconds per frame. So soon after you inject, you just run in renal study. Ideally, we have to use the camera positioned in the back of patient in upright sitting position,
upright. That's a physiological position. So it's by gravitational, it drained. If we put the supine, UV junction is like a hump on the supine. So some may not be drained well, okay? So, and also the other thing is that to have ideal renal scan, you have to hydrate patient properly. Hydration, proper hydration means 1,000 cc drink, either water, saline, whatever water drink, and 500 cc IV injection. That will make a proper hydration. Most centers I visited do not prepare such an optimal or ideal preparation for the convenience of patient, but that will make a inadequate curve analysis. For example, okay, and also this flow, the 0 to 1 minute, 60 seconds, this flow curve has to be also influenced by IV bolus injection. So if you, or if your nurse inject little bit continuously, you're not gonna have a good peak and down. It's just like this kind of curve, or slowly rising. So injection has to be in bolus. So there is some kind of machine, as long as you hook the machine into the vein, and machine, you put the radioactive material into the machine, and the machine can inject as a bolus. Then you'll have an adequate sort of a peak. So the DTPA is supposed to show, this is from aorta, outline aorta, and you look at it. So if you have a good peak and down, that's a good injection. Now, DTPA flow, it goes up to the kidney maximally in 30 seconds and down, wash out. Okay, but technetium MAG3 do not expect to see exactly the same. DTPA usually have a very good peak down. But because of this tubular agent, you certainly see the peak, but this down is just a little bit down, not like a much down here. And the that's from aorta. Even you have a good bolus, this happens. The kidneys usually go up and almost like stay there horizontally. So it's different because this is a glomerular agent. This is a tubular agent. Okay, but the important thing is about the good preparation and position of patient for ideal nuclear renal scan. So here, after 1 minute, every 3-4 minute consecutive continuous sort of a dynamic type static images for about 25 to 30 minutes will demonstrate how fast kidneys pick up, usually up to 5 minute maximum peak. Already all activities are in the collecting system. So from renal cortex down to renal collecting systems, you carry. And you can see the bladder coming down. So by looking this one, you can say a prompt uptake and excretion of the radionuclide or radiopharmaceutical, indicating good tubular function, excretory, tubular, excretory, and secretory and excretory function. And the other one with this shows a good blood flow. Then this, by visual inspection, this is aorta. So intensity of both kidneys is a little bit higher than this one. So it's a good blood flow, good coming in. And then usually DPA, you can see intensity down here, but MAG3 intensity just remains same. And obviously you can roughly estimate any abnormal size, small, larger, or some defect with a certain mass lesion, things like that. So again, now this is this is not a dynamic flow study. After 1 minute, you take just the consecutive static images. The right side is the right because this is the liver, right side. And the kidneys looks symmetrical, usually upper portion should be tilted toward the midline. If this is straight, and certainly retroperitoneal certain mass lesion can deviate a certain axis. The renal axis should be like this, but there is some variation. But anyway, from here it builds up. It should be, as I said earlier, like by 5 minutes, it should show maximum prompt uptake and excretion into the collecting system. But here, all activity continues accumulating, building up by this one or this one, and but you don't see any collecting system yet. All activity is retained in the parenchymal tissue. So if we outline, it shows obstructing curve. Left kidney, right kidney, almost symmetrically. It builds up. This is a obstructing curve, but as I said, it's a tubular obstruction or urinary tract obstruction. If this is a urinary tract obstruction, it should be very high up, like a uretero-pelvic junction. So in chronic uretero-pelvic junction, after usually 7 hours, it damages all the tubular cellular function. And so but in acute, usually show some activity coming into the collecting system and holding on this proximal, at the proximal portion of obstruction. So in this case, and also, certainly in this case, obstruction, and we should use Lasix. Lasix inhibits the reabsorption of certain sodium and also increase the peristalsis of ureter. It's stimulating vagus nerve, which is around the ureter, which makes a peristalsis. So that if there, as long as there is a tubular function, there is some activity coming into the urinary tract. And so that's what we usually do clinically. But this one is just an obstruction curve, but tubular obstruction versus urinary tract obstruction, you can take a further delay or injection of Lasix and then continue some image. But in this case, this is either acute or chronic interstitial nephritis. That's a tubular obstruction, rather than urinary tract obstruction. So as there have been lots of sort of studies, arguments about the outlining of area of interest. Is a whole kidney or cortex, ideally only cortex to evaluate renal function. You have to at least exclude renal pelvises, because renal pelvises, as I say, UP junction is hump. So if a patient lying down on the supine, then you already see increased activity retaining in this renal pelvis. Particularly, there's an anatomical variation. Some has a very large extrarenal pelvis. And then you make some difficult to evaluate. But if a patient is upright, it drained very fast. And the normal time activity curve should be like this. So outlining whole thing, and just the cortex actually makes about similar if there's no prominent renal pelvises. And so the peak should be around 3-4 minutes before 5 minutes. And from peak down, drawn this line and make a half, that's called T half time. T half time should be less than 10 minutes generally. 10 minutes. So again, and to evaluate split function, see the flow, and you can see this 0 to 1 minute. We have to look at aorta as a reference. If this is aorta, that's a very poor injection. Then you cannot evaluate this flow pattern properly. We should see at least some peak and down for bolus injection. But anyway, this is a renogram curve, and the it goes up. Peak arrived at about 6 minutes, and half time is down. So this now all the software show some normal values, and then the peak looks like about half. If any kidney, right or left kidney, has a less than 1/3 of total function, that kidney can be sacrificed. That's a very important information to urologists. If there is a sick, bad kidney, then there is a higher chance for usually infection, inflammation. And so it's better to take out if the function is less than 1/3 of total function. So that's what we generate by nuclear renal scan. So here, as I mentioned, dimethylcapital succinic acid is a glomerular agent, but it stays in the cortex much longer than DTPA and slow. So it's a fixation agent in the tubular. So you can see the delineation of the margins very clearly. So if there's any scarring, some hump, we call some physiologic hump, then they raise a question about some kind of tumor, etc. on CT, MR, ultrasound, then this agent will delineate the margin very clearly, particularly using SPECT CT. We can solve that kind of question and correlating with the CT. This is an old slide, but it was very helpful. Now using a better, higher resolution CGT SPECT system, this kind of things, small lesion, even small lesion can be evaluated better. So again, some example, you look at it out and, that's the right side, but here, right side, some, the margins are not clear. Here, you lost. So this is usually is a cortical scar that's after glomerular nephritis or pyelonephritis or certain cortical edema things, usually. Certainly, if there's a space occupying a lesion, you'll see it. So you have to correlate it with the CT, all things. So this is showing just a functional cortical parenchymal tissue of the kidneys by DMSA. So as I mentioned earlier in renal function, kidneys handles all kind of electrolyte, certain important, all this, particularly sodium, potassium, bicarbonate,
ammonia, urea, magnesium, calcium. So that's this is controlling all this. Certain absorption, excretion, all things. It's all related to all these vascular things together. So if there's hypoxia and narrowing or things, all these things are not working properly. Okay, so we clinically measure at least this kind of sodium, potassium, and chloride, bicarbonate, calcium, phosphorus, magnesium, and osmolarity. And this is a usual normal value here. So anything higher or lower than this value is a problem. So first, hyponatremia, okay, which is a common clinical problem. And then depending on the amount, we have lots of differential diagnosis. So isotonic, hypertonic, and then usually, and then this hypotonic, and so you can see so many conditions producing hyponatremia. So you have to go through all differential diagnosis. Yeah, too much drinking, and certain hypothyroidism also makes a hyponatremia. But yeah, certain congestive heart failure, liver disease, hypertonic, and certain kidney disease, dehydration, diarrhea, there's a hypovolemic things. So, and certainly hyperkalemia. And so it's a decreased excretion makes a high potassium in the blood. There's usually renal failure. So that's you have to always think about it, hyperkalemia. So again, lots of differential diagnosis. So hypophosphatemia, again, you have too much phosphate loss by renal tubular defect, nephropathy. That's a common things. And so now hypomagnesemia. Again, magnesium is lost too much by interstitial disease or some transparent kidney. So diabetes also produce decrease the magnesium in the blood. Hypocalcemia, again, chronic renal disease lost the calcium, and but the other conditions you have to think about it. Okay, and certainly secondary hypoparathyroidism, tertiary, secondary, tertiary related to chronic renal disease, and that's another thing. But in this case, sort of the other way around, and certainly vitamin D deficiency also brings this kind of hypocalcemia. So chronic renal disease makes metabolic acidosis. The metabolic anion is increased, and so that's again you have to rule out hypoalbuminemia or some diarrhea, other things. So metabolic alkalosis. And the clinically we do cell line and see the response, and then makes all this differential diagnosis. Renal alkalosis. So in nephrotic syndrome, okay, you have basically three things. In the blood, less albumin, so hypoalbuminemia. And certainly in the urine, proteinuria. And then edema. So that's usually clinical diagnosis of nephrotic syndrome. Okay, and so, and then important thing is that the this nephrotic syndrome makes a certain immunosuppression, and the certain the risk of bacteria, particularly streptococcal infection, and died. So when you have a particular cancer patient or a transplant patient, we use a lot of immunosuppressive agent. That makes sort of this kind of nephrotic syndrome, and then creating infection and died things. So it's some kind of vaccination things has been tried, but this is still a problem. Okay, so certainly reduce T cells lymphocyte makes less immunity, and the certain a lot of factors also join together for this phenomena. Certain complement activation is decreasing. So, so when we have a patient with edema, you have to go through all this differential diagnosis, hypovolemic or normal or hypovolemic. If hypovolemic, you use Lasix, and also spironolactone things, thiazide as well. But hypovolemia, just injection of albumin and some Lasix together and see the response. And the okay, it's been known to stage certain acute renal disease, acute kidney injury based on creatinine levels. As you see, stage 1, 2, 3, greater than baseline 3 times, stage 3. And then about 1.5, 2 times stage 1. That's related to survival. Okay. You can see a big difference. So stage 3 versus stage 1, the big difference in survival. Okay. So usually we have this, as I mentioned, BUN creatinine ratio. So if this ratio is greater, then and then there's a pre-renal vascular disease. It's intrarenal, it's usually normal range. And the free sort of fractional sodium less than 1 makes a pre-renal greater than 1. And also urine sodium It's less than 1 makes a pre-renal. So this way, by clinics, we usually make some distinction of pre-renal disease, intra-renal, kidney disease, and things. So by urinalysis, okay, we can differentiate glomerular interstitial nephritis, pyelonephritis, acute tubular necrosis, rhabdomyolysis, hemolysis. So basically, if you have a red cell in the urine, that's more likely related to glomerulonephritis. Urine shows hematuria, proteinuria. But if it's a white cell in urine, white cell cast, that's more likely acute interstitial nephritis, inflammation, things. So usually fever, rash, etc. And if you have a red cell, same red cell, white cell, and bacteria, and certainly urinary symptom, and that's a pyelonephritis. You know, between this one, the urinalysis shows similar. Only difference is the bacteria, pyelonephritis, and hematuria here, nephritis. But clinical urinary symptom here, pyelonephritis, but this one is just a fever and eosinophilia and things. And the acute tubular necrosis show muddy brown cast in the urine. And the rhabdomyolysis, that's coming from muscles, so creatinine is high. Hemolysis usually hemoglobin down, heptoglobin down, but LDH is high. So that's usually urinalysis. So if urine output is less than 400 cc per day, that's a clinical diagnosis of oliguria. So again, you have to entertain this kind of differential diagnosis. Oliguria is mainly from acute renal disease due to the sepsis, toxin, or certain nephropathy or hypoperfusion. But certain sympathetic activation, if pain, nausea, certain anti-diuretic hormone things, and this can also cause oliguria. So first you have to check any urinary obstruction by certain the CT things you treat. And so if not, then hemodynamic evaluation or rural diarrhea, vom, all kind of things I mentioned. Urine volume check and certain cardiac output, and then renal disease and this kind of things. And so if urine output is improved, then continue. And then therapy, but otherwise you have to find out any renal damage. Okay. We have a lot of causes for renal failure. Okay, certainly vascular disease, as I mentioned earlier, all kind of hypoxia, intrinsic or extrinsic. So cardiac disease, other things, emboli, thrombosis, disseminated intravascular thrombosis, hypertension, all kinds of vasculitis. So small vessel, microvessel disease, and diabetes, all things affecting the small vessel. A large vessel, embolus, thrombosis, certain that kind of things. But inside the tubule, you have a tubular certain toxic effect, tubular ischemia, It's a very acute ATN. Right after the transplant, you expect some ischemic ATN. But the rhabdomyolysis, hemolysis, contrast agent, cisplatin, gemcitabine, all these toxic damaging tubers can cause this renal failure, and certain endogenous IgM protein that's in the multiple myeloma, and certain uric acid tumor lysis syndrome in many cancer patients, uric acid, and certain acyclovir. There's antiviral drug sometimes cause this intratubular disease. Now this interstitial between tubers, inflammation, allergic, and certain lymphoma inflammations. And so there's a lot of causes for renal failure. And basically we divide into three: pre-renal, post-renal, and intra. So pre-renal usually vascular things, renal arterial stenosis, I think. Intrarenal, all the tubular damage, toxin, drug, inflammation. Post-renal, urinary tract obstruction, that's a main. And certainly bladder disease or prostate, urethra, that all retrograde inflammation, and also reflux after cystectomy. Okay, there's a denervation of vagus nerve, make a reflux of dirty urine and damaging all the renal tubers. That's quite a common in patients with the bladder cancer. And that eventually makes a renal failure. So in chronic renal disease nowadays, diabetes contributes to almost half. So this is a serious problem, diabetes. Diabetes is basically related to microangiopathy that affecting the brain, heart, kidney, all the things. And certainly high blood pressure, hypertension, damage. And the other polycystic kidney, glomerular, this is a very small portion. So hypertension, diabetes are two major problems in renal chronic disease. So certain reversible, certainly if we detect early infection by urine culture, and then we can almost reverse obstruction, also bladder catheterization, renal ultrasound, extracellular volume depletion, and we can check things. And hypokalemia, hypercalcemia, this electrolyte all the problem. If we detect early, we can correct. If we know certain nephrotoxic agent, particularly cisplatin, all things, we stop, and then so hypertension, we check blood pressure, and the clinical history, congestive heart failure, again, now we know. So those are things. In diabetes, you can see serious problem for renal failure. Okay, so quite a incidence is going up, and it's quite a large number of patients end up end-stage renal disease due to diabetes, and then they are on chronic dialysis or renal transplant. So that's a problem. So in type 2 diabetes, starting with the functional changes and then later structural changes. But blood pressure rising, microalbumin. So urine, albumin in the urine starting, that's the first. So in diabetic patients, they always have to check urinalysis. If blood sugar is not controlled well with the medication, they must check albumin in the urine. So starting here, they have to check renal function and cardiac function together. So once they have proteinuria, creatinine high, or GFR lower, then that's it. So that's it's a long time period. It's a significant clinical and social problem. So as I mentioned, it's like a microangiopathy, all this small vessel disease, blocking, leaking. Once a block leaking, so it damage all this retinal, eyes, make a blind. Small vessel, heart is a problem. Kidney, same. All this is the same endothelial damage, all things. And then platelet plays also a role. So in diabetes, there's hypertension, self-damaging glomerular, but there's certain glycation and the overproduction of cellular matrix also damage. And the protein kinase C and some growth factor also affecting nephrons. So this is sort of mechanism. So there's an important gene, ADAMTS13. This sort of protease, this less than 10 indicating thrombocytopenic purpura. And so this gene is important in relation of thrombosis or nephropathy. This kind of things has been recently studied and tried to. So I mentioned already briefly, certain right after transplant, there is a called ischemic ATM. It's sort of a shocking state. Any shock state is a hypoxia, and sort of a vessels, small vessels become shrunken or spastic, and then there is a acute tubular necrosis. In that, maybe blood loss, fluid loss, some hematoma, and some vasodilatation, and the renal vascular disease. So again, if there's a ischemia, the tubers are affecting. So intercellular calcium may be increased, and then certain sodium, potassium, ATP kinase also decrease, and sodium reabsorption is decreased. And so it's, and then eventually all glomerular filtration is down. And the certain nitrous oxide, caspase enzyme, and proteinase, all these certain genes contribute this kind of increased necrosis, apoptosis. And then there's a tubular obstruction. Tubular obstruction can be occurred also by certain aberrant sort of vascular endothelial sort of growth factor substance, integrin, and then there's certain adhesion, certain molecules, it makes a cast formation. It's a blocking. So that's also a mechanistic explanation for ischemic acute renal failure. That mentioned, it's all relationship. Sodium, this nitrous oxide, that's important for maintaining sort of a blood flow. But if that is decreased in the brain, it's sort of a cyclic things, and then generating certain growth hormone, make heart trouble, arrhythmia, ischemia, heart trouble, and certain vascular construction. constriction, atherosclerosis things. And then affecting also kidney, sodium retention, hypervolemia, and some proteinuria, glomerulosclerosis. And that was certainly because of vascular narrowing is hypertension. And certainly hypertension is affecting by leptin, that's certain protein contributing this. And the obesity, smoking, certain cholesterol problem, also oxidative stress, inflammation, all these things contribute. And so make a high blood hypertension. So renal schema also produce adenosine. That's so erythropoietin usually in the kidneys and some also in the adrenal, liver, small. But kidney, if this is a major organ and damage, and obviously you expect to see anemia, very pale face. So these are all sort of in one axis integrated together. So in ATN, many antibiotics, particularly it's common Cipro, we use vancomycin, all antibiotics apparently damage tubers. And certainly aspirin type or agent and diuretics even damage. So if you use any drug longer than certain amount, and you see here all kind of drug we are using, captopril and viral antiviral drug, all kind, even Prilosec for gastroesophageal reflux, and certain thyroid medication, and even the seizure medication, Dilantin, or Zantac, all every kind of drug cause this tubular necrosis. So we should prescribe any kind of drug in limited time and also for absolute indication. Certain this kind of drug, analgesic renal failure, increasing papillary necrosis, interstitial nephritis, all things. It's well known. And then you can see renal normal kidney on CT show very good outline, smooth, and enough thickened cortex. But renal failure cause irregularity and scarring, and kidney cortical thickness become less, and then small atrophy kidney eventually. So it's a bumpy from diagram here, in the indentation, 0 to more indentation, all things. So if you slice here some, this kind of things could look like a tumorous bump. So we can evaluate tumor cannot take up DSMA. Yeah, so only normally functioning renal parenchymal cortical tissue takes up retained DMSA in the tubers. So that's what's, and then some papillary calcification. You can see calcification things in the papillary necrosis. So we have lots of differential diagnosis based on clinically BUN serum creatinine, as I mentioned, usually 15 to 20 normal, greater. So usually pre or post renal. And then less is inside, but some glomerular higher. So, and then certainly urinalysis, particularly sediment, and certain sodium, and free excretory sodium, urine osmolarity. So this kind of things clinically make a differential diagnosis pre-post renal azotemia, ATN, acute glomerular nephritis, interstitial nephritis. Clinically, they all look similar by symptoms, but by difference of BUN creatinine ratio and some this urine sodium amount, free sodium, and osmolarity, and some urine sediment shape differentiate. So again, this differential diagnosis of acute renal damage is a normal or few red cell, white cell, hyaline go through this kind of differential diagnosis. But in the abnormal, you have to have some specific, there's a separation. Is a eosinophil, granular cast, crystal, and this pigment cast or white cell cast or red cell cast for differential diagnosis. Again, by blood, if there's a muscle damage, rhabdomyolysis and the creatine kinase level is supposed to be high. Gouty, nephropathy or malignancy, you have uric acid high. Yeah, malignancy in general, calcium high. Multiple myeloma, particularly that's IG. And sickle cell, hemoglobin, sickle cell, you can check HIV. There's post-streptococcal glomerular certainly anti-streptolysin or elevated. And hemolytic uremic syndrome, hemolysis, you can check. Autoimmune disease, anti-nuclear antibody, you can check. Lupus, DNA antibody positive. So that's what clinically we usually do. Okay, now we have, oh my gosh, already. Okay, we'll have a 10-minute break and then finish up the imaging part. Okay, 10 minutes. Okay. All right, we'll continue. Okay, you already know the renal angiotensin aldosterone system to explain renal hypertension. Renal hypertension is caused by constriction of renal afferent arterial, and or increased blood volume, which is influenced by angiotensin 2. Angiotensin 1 is converting to angiotensin 2 by angiotensin converting enzyme, which is produced by the lung. Captopril inhibit this enzyme. This angiotensin converting enzyme becomes very now important in understanding current COVID-19 virus. Virus has a very spiky protein in the wall, and that has to be entered our body cells, but in that entry is influenced by angiotensin converting enzyme. So that has now currently studying. And this angiotensin 1 is from angiotensinogen, which is produced by the liver. And this angiotensinogen to angiotensin 1 conversion is influenced by renin, which is produced by kidneys. So if there's a kidney damage, you may increase the renin, and then through all this process, you might end up having hypertension. So again, in normal physiology, comes glomerular filtration, and then tubular secretion. There's a maintaining glomerular filtration rate if there is no vascular narrowing. But if there is a vasoconstriction of afferent arterial, then you cannot go through here, so you go more here, here. And so if we use catheter removing this angiotensin 2 role, then this GFR is reduced. So in the catheter study, we expect to see reduced GFR on the curve. I will show you. So in the evaluation of renal vascular hypertension, by the way, about more than 90% hypertension is idiopathic. So renal vascular hypertension is a very small percentage. But if there is any questionable renal arterial stenosis or intrarenal arterial blockage by extrinsic or intrinsic region, then you can have this test usually run by 2 DTPA or MAG, either one is same. So first, before the use of captopril, and then after. So if there's a decrease of GFR on that side, that's the abnormal side. So because it reduces GFR by captopril in patient with the renal vascular hypertension. Okay, ultrasound show certain, maybe some shrink renal parenchymal tissue, but the nuclear medicine study basically show some abnormal GFR function after captopril. Certainly ultrasound or angio, ultrasound show high resistance in renal stenosis, renal arterial proximal arterial stenosis, as can suspect. And then angio can show certain narrowing of certain a small renal arterial branch. And so if there's a severe sort of decreased renal function, and then you can have MR or duplex ultrasound study, and then certain renal scan, perfusion function, and then make a diagnosis. Okay. After medical treatment, controlling blood pressure, and then you make a renogram, and then if there's a positive probability, then CT angiogram, MR angio, and that makes a certain revascularization procedure. And so certain, see the cortex here, this is a medulla, but here you see some echo sort of free certain, that's a dilatation of collecting system. So that's a hydronephrotic thing. So water, sort of echo-free area, or this dilatation. And this is a sort of a thin cortex here. And there's a prostate embedded into urinary bladder. So the prostate's enlarged, and the sort of distal ureter is dilated. And so there's a lots cystic, solid, some stones, post-acoustic shadow, right? If there's a stone. So ultrasound is useful for evaluating stone, cystic, but again, ultrasound evaluation is all dependent on the individual operator. A transducer's operator makes all different. So prominent certain pyramids on acute renal damage, and certain hypoperfusion by ultrasound. And it's, so
usually CT is liver is here, and kidney looks small and thin cortex. So it's a chronic atrophy renal disease we can suspect. And certainly very thin cortex and some dilated renal calcium, so chronic atrophy renal disease. And this contrast study has been always, risky. So you check patient GFR. If that value is less than 60, there's a risk. And it's less than 30, then we have to worry about the, some potential problem. So if there's any underlying known renal disease, GFR is low, try to avoid the contrast, the CT or MRI. That's a basic. And see, you have a striated nephrogram and small atrophy kidney. And the this here it's a venous phase. You have to see nephrogram. You have to delineate cortex, medullary clearly, but you see all things is sort of the chronic renal, acute renal disease, some vascular problems you can suspect. And then after coronary angiogram, the one day earlier still show contrast and retaining the cortex. It doesn't drain. This proximal ureter, it should drain. So there is some tubular, secretory problem you can suspect. Bacterial pyelonephritis, focal, so mass-like, filling defect. You can see various, some gas is sort of gangrenous. It's a sort of pyelonephritis. You can suspect microabscess, I think. So certain, the contrast is leaking. So here, contrast study, it's a retaining, it's a leaking. Some abscess, hematoma, maybe some here. It's before the contrast, some high density suspecting hematoma. And the leaking here, and then with all this mass lesions. And the you can see again some, this is a, arterial phase. You expect to see some good, either nephrogram or cortical medulla, you don't see. You'll find some mass or something here. So it's a renal disease suspected. This MR, again, or collecting system, but very thin cortex. So in the MR, there are many different techniques for perfusion, function, metabolism, that's a spectroscopic metabolites, even pH measurement, and some using diffusion imaging, tractography, fibrous injury, cell death, magnetization transfer technique, and certain oxygen delivery using bold technique. So many, different per sequence, but generally we don't do that because there's enough other tools, simple, easier things. So this patient had the pre-operative kidneys, looks good, contrast, and after they remove the left and right side, you don't see much contrast like this. So there's an immediate sort of ischemic ATN and slowly filling in here. On arterial, you should see good kidney cortex. And the certain perfusion abnormality on, MRI is normally you have to see cortex, medullary junction, and this is platinum.
show excretion, but the distinction. And severe is just retaining the cortex. It should come out some. So on MRI, you can see it. So MR, certain arterial spin technique can also evaluate the ischemic ATN. Particularly, they use a certain immune cells as a marker, macrophage and fibronectin markers, and see. That's also in the research. Certain inflammatory marker labeled with the gallium-68 in the PET scan. The MR shows some decreased signal in the posterior aspect of transparent kidney. That area showed increased uptake of CXCR4. That's an inflammatory marker. Antibody showing specific. So in renal mass, we have lots of differential diagnosis. Obviously, renal cell cancer in relatively elderly, and angiomyolipoma is rather middle age, common benign, but this one has a lipoma. Has sort of a fat density on CT, so easy to diagnose. And then transitional cell carcinoma, now called urothelial cancer, which is affecting not only renal pelvis, ureter, and also bladder, so all together. So that's also elderly. So other things are rare, adenoma, metastasis, lymphoma infiltration, polycystic kidney is easy, is multiple things, only hypertension sometimes, but we have many concern about renal cell cancer, angiomyolipoma is benign, and transitional cell carcinoma, mostly affecting urinary tract, this one. But this affecting is the renal parenchymal tissue. This one doesn't make hydronephrosis. But this one makes a hydronephrosis because it affects, it blocks urinary tract. This one doesn't block urinary tract. So physical exam, all this clinical is very similar, but basically depending on ultrasound, CT, or sometimes MR, we make a differential diagnosis. So renal cell is about half. And but you have to separate oncocytoma. It's a high density on CT somehow. But transitional cell carcinoma, lymphoma, metastasis infection, they all look alike. Cystic is easy. The outline very well. And then this leukemia, sometimes like a tumor. And so we have to always keep in mind renal cell. There's also cystic nephroma, which is very difficult to separate from cystic benign tumor. So it's some show a ball, like a ball. Okay, that's renal cell angiomyolipoma, oncocytoma, metastatic lymphoma. But being like transitional cell, renal cell lymphoma, some overlaps the things. But to me, renal cell doesn't obstructing urinary tract, but transitional cell obstructing urinary tract. So on CT, you have to check fat first. If there's a fatty density, low density angiomyolipoma, enhancement, renal cell is highly vascular. Renal cell. No enhancement, that's cyst. If there's enhanced, how much enhanced? Mild, vivid, very vivid renal cell. But slight, whatever, and pseudo enhancement, some other thing. Clear cell, which is the most common renal cell, that's a very vivid enhancement. Mild, other type papillary things, or oncocytoma benign, but the oncocytoma on CT is
It's a high density. That's so it's a transitional blocking, or collecting system, and transitional. So sometimes renal are infiltrating in parenchymal tissue. Lymphoma diffuse. Lymphoma diffuse or sometimes focal. It's very metastasis, usually well defined, and enhancement in the periphery. That's a metastasis. Pyelonephritis is very non-uniform, sometimes air things, in fact, certain segmental, low perfusion things. Many look alike. So clear cell is a 70% renal cell, usually in the cortex. It's pensile, vascular lesion, highly vascular. But sometimes it shows a fat. Calcium, that's a problem sometimes. 5% inferiority and certain, yeah, so this kind of things here. And it's difficult to see without contrast enhanced. Unenhanced here, enhanced, but it's sometimes because of this renal tissue also very vascular. And so we have a arterial, venous, capillary phase all together. And the papillary is a relatively small percentage. It's not that vascular, so it's shown here. And for multifocal, and sometimes bilateral, that's a papillary type. The chromophobe, that's a much smaller rare. It's almost like a central scar. Oncocytoma, it look like, but oncocytoma on CT, the density is much higher. So oncocytoma is here, without contrast. Contrast somewhat, a little bit enhanced. MR show here. And so it's again, renal mass on MR, we separate. If there's a T1 high, that means it's a bleeding or a fat. That's angiomyolipoma. And certainly in out of phase show decreased signals. That's a fat. And so we can separate on MRI. And the classifications, usually at the time we usually diagnose renal, usually about T2, greater than 7 centimeters. They don't have a symptom until they reach the 7 centimeter. Okay, and so 4, 7 by size, stage 1, 2. And always check renal vein, portal vein, adrenal gland, and then extension outside the kidney through the xerotas fascia. But in my experience, almost all clear cell renal cell goes to the lung. It's a matter of time, but we usually detect within 5 to 7 years after initial diagnosis. They all go to the lung. So certain small lesion is difficult for differential diagnosis. It could be renal cell, it could be benign, all kinds of things. So you have to watch and carefully things. And the diffusion imaging show sometimes high, sometimes a little bit low. And it's the by side, some big, small, as I say, greater than 7, less than 4 stage. Usually, even with this large size, you don't see hydronephrosis, but regional retroperitoneal lymph node metastasis. And the small, tiny, little bitty bump outside, very difficult to diagnose, little bitty, So just watching and ultrasound altogether, other things. So cyst, this is a cystic, only peripheral enhancement, cystic renal cell cancer. Very difficult to separate from benign cystic lesion. Some classifications. Cystic nephroma, this also cystic malignant tumor. So well marginated, looks like a cyst, but some kind of internal fibrosis. And so it's a slight heterogeneity is a hallmark of malignant tumor. Inside, it's some hemorrhage makes a signal difference on MRI. An important thing on renal cell, any tumor invading renal vein and going into the portal vein, it's tumor, huge tumor. So here, renal vein. So always make sure a tumor filling renal vein and going into the superior venous, inferior vena cava. And certainly renal cell can go to any place. Once they go to lung, then go to the bone, liver, and even soft tissue, usually expansile, enhance, that kind of expansile. And urothelial, on the other hand, is transitional carcinoma. 15% infiltrated, elderly, usually obstructing renal, urinary system here. Yeah. But it's a small urothelia, small. But the hydrogen is small here, yeah. Hydronephroid dilatation, because it occurs in the urinary tract. It's all dilated, the collecting system. And here, pre and post contrast, the renal pelvis here enhanced, so eventually blocking draining system. And the here the CT without contrast shows some low density fat. That's a fat angiolipoma. That's a commonest benign renal tumor, fat. So that's but sometimes renal cell cancer also look like. So this enhance things. So it's not easy to completely separate it. Okay. So metastasis to the kidney, mostly from the lung cancer, breast melanoma, like everything else. And then also tumor, retroperitoneal lymph node, the tumor here. That's a metastasis, but you cannot separate from renal cell tumor, same appearance. And it's a whole body. You can see lots of lung lesion and some largely. And the, this is a PET showing all these lesions. And the renal leukemia also sometimes makes a certain mass like here, nodular things. The PET CT shows some retroperitoneal lymph node, but this is a leukemic mass. Certain pyelonephritis formed a certain mass, ill-defined, infiltrated, and enhanced. So it looks like a tumor, but it's a pyelonephritis, multifocal. So you have to combine it with certainly gas formed mass is emphysematous pyelonephritis. You have to certainly separate from renal cell with para-renal fat. So it's not easy. So all this xanthogranulomatous pyelonephritis, all this, so granuloma together and things. And so that's, and the, this kind of acute pyelonephritis, and the certainly you can see some kidney is like a line, sort of a laceration kidney things, and certain it's sort of ill-defined infiltrative process. Yeah, it's a chronic glomerulonephritis, and usually cortex is a small kidney here, narrow here, small, and the And certainly infarct sometimes makes, but usually it's a wedge shape because it spreads through the arterial flow. So it's a sort of filling defect. Certain pseudo-cystic, well-defined with the contrast, very looks like a cyst. That sometimes that's called Burton column of Bertini. Burton. That's a sort of anatomical variation of hump in the cortex. This looks more inside, but actually it's hump usually arising from the cortex, like bumpy things. And the renal cyst is sometimes confusing. Peripheral renal cyst. So ultrasound, MR show very easily cystic. So there are many cystic lesions, simple cyst, acquired cyst, certain polycystic renal disease, medullary spongy cystic, medullary cystic kidney. It's all the hematuria, hypertension, those are the cysts. And the so ultrasound by location holding usually handles this differential diagnosis. So uncomplicated cyst, the no contrast enhancement at all, no septa. That says ill-defined margin air bubbles. And the complicated cyst, traumatic cyst, or show some calcification things eventually. And the most important thing is a different cystic hyponephroma, renal cell cancer. That's a problem. So enhancement in nodular shape in the wall, particularly periphery. And then multiple lesion, usually polycystic kidney, echinococcal cyst, and so the margin, the Bosniak classification is a 1, 2, 3, 4, 5, depending on the. It's a simple cyst 1, category 1, but the 5 is a malignant. Usually enhancement of soft tissue mass inside the cyst. And 4 category is a probable malignant, irregular or irregular. Indeterminate is a septal contrast enhancement. And some benign is some categories, not easy. So greater than 3 and 4 category, that's a probable malignant. That's what we are concerned. And we end up having ultrasound, MR, CT, all things usually. And then eventually some biopsy or thing. But short follow-up every 6 months, because these tumors are slow growing in general. So ultrasound was CT, MR, frequent follow-up, usually show any changes. And then the biopsy. Small is this a simple cyst or cystic nephroma? You can tell. Margin is with contrast. Margin is so clear. So it's more likely benign simple cyst on contrast study. Certainly renal and para-renal, all the cysts. No obstruction of urinary drainage, and the benign multiple and calcium in the, that's a benign, but this kind of things, it's not easy. Some angioblastoma is another rare benign tumor. So some simple, complex, and multiple poly. And so multiple cystic and the anterior posterior, you say some function there, but on the only one side.
So complicated is a cystic, margin is complicated. Yeah, but some regions are not. With this T2 is or cyst fluid is show sort of high signal, margins are clear, but some are not clear, and then so it's some little complicated cyst. Polycystic kidney, multiple bilateral. This is MRT2 show multiple large and small. It's a classical. And then obstructing acute renal obstruction is based on a lot of congenital anomaly, diverticular, particularly urethral valve, and then certain BPH, common, and certain stone, and certain malignant disease like prostate cancer, bladder cancer, urethral cancer, cervix, colon. It's all extrinsic compression, or sometimes breast cancer metastasized. And retroperitoneal fibrosis, idiopathic or certain trauma thing. Gynecological, pregnancy, anything extrinsic compressing distal ureter will make obstruction. And certain uric acid nephropathy, certain drugs, and certain infection, tuberculosis, aspergillosis, etc. So if you have obstruction or reflux uropathy, and then supravesical, that's anything just above the bladder obstruction. And urethral kinking is also retroperitoneal tumors, certain congenital. And so it's a mechanical obstruction versus what we call functional obstruction. Usually ureter is not peristaltic. So as I said earlier, after cystectomy or denervation of vagus nerve and ureter is not working, then urine is going back to the kidney and makes our nephropathy. And so that's, and also many chronic extrinsic compression by certain vessels or certain mass can cause certain functional obstruction without mechanical obstruction. So you have to separate it. Certainly stone will make post-acquisition, this stones. And certain, this bladder, certain jet, ureteric jet. So it's a tiny radiopaque stone here, doesn't obstructing much. Here drain down. After drink a beer, usually shoot it down here, but it's so painful when they travel here. Yeah. And so dilated the certain correction system pelvis. And the hydronephrosis, so the renal pelvis so dilated, and the cystic mass is all dilated collecting system. And you can see on MRI, so easy to see dilated collecting system, T2, T1, and the retrograde parogram show or dilate, and maybe some obstruction here at the uretero-pelvic junction. And the MR urogram without injecting is so heavy T2 weighted image will show. So dilatation of ureter, so some obstruction at the uretero-vesicular junction, either by stone, tumor, whatever things. So we used the Whittaker test, put the nephrostomy and measured mercury, certain. But this technique has been abandoned. Usually around 15 centimeter sort of water pressure, but the separation of obstructive versus functional, mechanical versus functional obstruction is not so clear cut. There is some gray zones. So this invasive is not accurate. So it's clinically almost abandoned. But we still use a nuclear study So like this, okay, we have a sort of a serial, nuclear renal scan. You can see prompt uptake and excretion by the right kidney down here, but the left kidney, you see increasing activity, and then accumulating in the renal pelvis, stop there. So you suspect some partial or complete obstruction of left side uretero-pelvic junction. So by nephrogram, peak and wash, that's from the right kidney, but left side goes up and down a little bit things. If this go up, that's a complete obstruction. But a little bit down, there could be partial obstruction. Okay, so there is a slight, okay, this is a certain kinking thing, peristalsis. This is what we expect to see normally, things. So it is a peak down here, T-half here. So this one usually is less than 10 minutes. So this is an obstructing curve, going up, 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 up. And then after we inject Lasix here at this time, and to see how they're responding. Okay, maybe I'll explain it. But so after Lasix injection, if this go up, that's a complete mechanical obstruction. If this one down here, that could be partial mechanical obstruction or functional obstruction. Functional obstruction. So how you separate partial mechanical obstruction versus functional obstruction? So you have to generate T-half. This is a maximum T-max here. T-half measure like this. If T-half is less than 10 minutes, okay, that's the functional obstruction. But if this is greater than 10 minutes, that's a partial mechanical obstruction. Okay, partial. So in functional obstruction, you usually use hydration and Lasix for the treatment. But any mechanical obstruction is a surgery or nephrostomy or some, retrograde. Urologists usually look at a retrograde study and then make a decision. So this is a vesical ureteral reflux in pediatric patients. So as you can see also here, you can have a grade, depending on what you see, the ureter or kidneys or things. So this secondary hypoparathyroidism, I mentioned when I discussed about the parathyroid, and then if there's a renal failure, okay, and there's vitamin D and the calcium decrease and growth hormone produced that makes a stimulation of osteoclast in the bone, and so and this, when the vitamin D down, calcium down, then parathyroid activating, and then makes increase the parathyroid hormone and calcium. That's a secondary hypoparathyroidism. So it's also, and there's a nephroencephalopathy, and showing some abnormality and more likely white matter area, diffuse things. Encephalopathy will show certain this is the basal ganglia area, and maybe grow right side the globus pallidus show uremic edema. This edema, uremic edema here, and that's a cytotoxic uremic edema, and that's been well known. So chronic renal disease, renal damage greater than 3 months, and GFR is less than 60 minutes per minute per 1.7 square meter for more than 3 months. That's called chronic renal disease. And by GFR stage by GFR, usually GFR greater than 90 cc per minute per
1.7 square meter, normal. But it's down. If you have less than 30, that's usually chronic. Where less than 60 is chronic insufficient. So down here. And then this require transplant or dialysis. So chronic renal disease, all no energy, all things, some hypertension, anemia, that kind of thing. And so you have certain medical treatment. You have to have a proper protein diet, a restriction of certain sodium, potassium, phosphorus. And so you have to correct hypertension, certain atorvastatin helpful to lower down cholesterol, erythropoietin suppression to correct anemia. As I mentioned earlier, diuretics to wash to fluid better, and certain supply calcium, vitamin D for bone, other parasite problem. And so again, it's a similar thing. So at the end of dialysis is the peripheral vascular dialysis versus peritoneal dialysis. Peritoneal dialysis makes more risk of peritonitis, infection, and things. So it's a very miserable. And certain transplant, we have to talk about transplant, which is now common because the less side effect usually have a lots of ATN and rejection. But now with the many new drugs, it's very popular. So basically, and earlier we have to separate ischemic ATN, that's and then ATN, that's a tubular problem. And rejection, acute rejection is a vascular problem, obstruction of sort of a microvascular disease. And so if MEG3 shows this is a flow path, and renogram, if this is going up, like obstruction, in the beginning, that's mostly ATN. But if flow down and function down, that's mostly rejection. So beside the ATN rejection, we have lymphocyte, urine leak. That's it. But this kind of things is now rare because the surgery has been improved. But we still see lots of lymphocyte because they denervate, they dissect the lymph node. So usually, we entertain acute rejection and ATN here, later some urinary obstruction, rejection. And the this MEG3 continuous accumulation without dilatation of collecting system or ureter, that's a tubular necrosis. After day 6, it washed out. And usually MR can make it also good. It's a sort of delineation of renal vascular system and perfusion in the kidney. And urine leak is still some problem because the connection is not well. So unexperienced, some surgeons make this problem. You can see activity leaking out, accumulated here. So certain delayed image is better to see the dispersed activity in the pelvis. And the urinoma, urine leaking, basically, you can see with MR without contrast, just the continuously leaking. But nuclear medicine study can do the same thing. There's a mass right here, feeding defect without obstructing ureter or calyxes. That's a urinoma. Not urinoma, that's a lymphocyst. So the MR can show sort of a fluid retention. So it's a urinoma versus lymphocyte, you can tell. It's just a connection you have to study. Okay, so it's again, for final things, for diabetic renal disease, you have to control blood pressure and certain blood glucose, some dietary weight, other things. And there's some filtration, glomerular filtration markers here. And so ideally, you have to have some completely eliminated by the kidneys and constant process. But inulin is the best marker, but it's not. So clinically, we use creatinine, but as I mentioned, creatinine is not accurate. So usually combining things together. So now a new test is called cystatin C is working in some certain hospitals. It's still, there have been a lot of research. This cystatin C is a protein, and it estimates a fairly well glomerular filtration rate. So a simple blood test show, and then there's been a lot of report of better than creatinine and reflecting renal disease. So creatine plus cystatin C certainly makes a better estimation. So clinically they use both. But chronic renal disease. So in the UK, they started with the UK, and the cystatin improved the prediction of cardiovascular disease as well as the kidney disease. Okay, it's too low, then you certainly have to exclude the low albumin. But you have to think about chronic kidney disease, and then you have to measure glomerular filtration rate by blood. So I just went through various renal diseases, and the imaging studies, anatomical studies by ultrasound, CT, or sometimes MR, practically usually ultrasound or CT. And that's mainly helpful for space occupying lesion, but they have a limitation of separating cystic nephroma, particularly small one, from benign cystic lesion. And that's still a problem. And the nuclear medicine study is helpful for functional aspect, particularly split function for urologists, and also evaluation of renal vascular hypertension, and the and also a certain basically renal functional status is a glomerular function or a tubular function. So combining with the blood test, either GFR, creatinine, or some cystatin C make a good judgment. But we like to continuously work on more, maybe specific agent or more accurate quantitative assessment of renal function. And furthermore, we diagnosed cancer or renal disease very late in general. Somehow routine blood test doesn't predict a certain renal disease far in advance. So we need more research for that regard. So I'll stop here. If there's any burning question, you can raise now. Otherwise, you write down questions, comment, criticism on your evaluation form. And I thank you very much for listening my talks in this semester. And I'm sure I'll do some thing next spring and next probably fall. I originally planned to give you a talk on more research topics like tumor immunology and tumor metabolism and tumor genetics. I may do that next year, but that's a little bit still far away from clinical practice. But you may have to know that kind of information in considering your research, or at least your interest. We'll think about it. Okay. If you don't have any question now, our agenda meeting, and I hope you keep good health and enjoy your work and have a nice day. Bye-bye.